So, cardiomyopathy, endocarditis, all the other heart valve issues. Cardiomyopathy. There's three types of cardiomyopathy. Cardiomyopathy means that the heart muscle's getting sick. So, dilated, the most common. All four chambers of the heart enlarge. That's going to affect your contractility and cardiac output. That's the most common one. There's another one called hypertrophic cardiomyopathy. The least common is called restrictive. This one has a high risk for emboli. So dilated, all four chambers of the heart dilate, grow bigger. Causes could be viral infection, chronic alcohol abuse, anorexia. There is a peripartum cardiomyopathy towards the end of pregnancy that some patients come down with. That's not permanent. It's just a complication. So assessment. All the cardiomyopathies, because it affects your cardiac output, and are going to have fatigue. So cardiac output decrease is going to cause fatigue. If you can't get your cardiac output out, the blood can't go out, then you're going to have crackles in the lungs, so it backs up. This is a lot like heart failure. You're going to have dyspnea. It's common to have a murmur, so an S3 and S4 murmur. So it's important for these patients that you need to monitor vital signs, lung sounds, edema, activity tolerance. We're going to treat and monitor the same kind of things that we do for heart failure patients. We want them to pace their activities. We want to reduce their edema. We want them to have as few crackles as possible. We want them to not be short of breath. We want them to be able to have a normal life and do whatever they can. So how do we test for that? We can do cardiac catheterization. We can do an EF. So patients that have a really bad EF, like less than 20%, usually have a year prognosis with cardiomyopathy. Chest x-ray, you would see the enlarged heart. You could do an echocardiogram or a TEE. You'll probably see changes on your EKG. Treatments, this looks just like heart failure. You want to rest, pace your activities. These patients, because there is no cure, unless they get a transplant, their whole life has changed. So psychological issues. So treatment with meds, just like heart failure. Diuretics to keep fluid off. You want to watch their blood pressure, doesn't get too low. Low sodium diet. Don't want them to take in too many fluids. There's a medication out there called dobutamine IV. That is like giving someone digitalis, digoxin. It basically works faster, it lasts longer. So some patients with really bad heart failure and really bad cardiomyopathy, if they're admitted to the hospital, we give them dobutamine, and that will help kind of energize the heart. It lasts for weeks, maybe a month, 2 months, and they feel so much better. So that's a treatment in the hospital. Patient getting a transplant, that's the only recourse really. They have a lot of strict criteria. You can't have a systemic disease that you have less than 2 years to live with that other disease. That is a criteria. This is pretty standard for heart transplant. You can't have AIDS, you can't have lupus and sarcoidosis. You also cannot have obstructive pulmonary disease. So that takes out a lot of patients that have COPD. And a lot of emphysema and bronchitis patients have COPD as well. So there's a big category there of patients that would not be able to get a transplant. Pericarditis. Pericarditis, we talked about a little bit before. Pericarditis, the inflammation of the pericardium, that's the sac around the heart. It's usually viral. There is a chronic form of pericarditis that the pericardium thickens, becomes very fibrous. So it can be post-MI. MI can cause pericarditis. There's also a form of pericarditis that is called Dressler syndrome. It happens 4 to 6 weeks after an MI. So if somebody has an MI, we send them home with their meds, say, good luck. Why do we want to follow up with them 4 to 6 weeks or in that time period? We want to make sure they don't go and develop Dressler syndrome pericarditis. So assessing pericarditis, if that gets too enlarged, then they're going to have pleuritic pain. So it hurts on inspiration and lying flat. Some patients say the pain radiates to their trapezius because the phrenic nerve is right there in the shoulder. They may have a friction rub as you listen to their lung sounds. Probably have a increased WBCs because it is an infection, but it might be a low-grade fever because it's usually viral. SED rate will probably be increased. On a EKG, you might have ST elevations, but they don't resolve. The ST elevations on an MI, they resolve once you open that coronary artery up. Well, we can't open it up, so they're not going to quickly go back down. So if you have chronic pericarditis, dyspnea, fatigue, it can progress to CHF because that enlarged pericardium does not allow the best cardiac output. So the heart's going to beat harder and harder and harder, and it's going to be more difficult, and the patient may develop CHF or heart failure. Complication of pericarditis, you all remember, is cardiac tamponade. The way you diagnose that is do a pulsus paradoxus with a blood pressure cuff. Also, these patients, because of reduced cardiac output, would have narrowing pulse pressure. Narrowing pulse pressure is what? Do you remember that? And prominent finding, because fluid is backing up, JVD distension as well. So these patients, if they're in the hospital with this, or at home, they need to be sitting up. That'll help them breathe. It'll help cardiac output. Give them anti-inflammatory meds. You need to treat for the decreased cardiac output so they'll have better oxygenation. So give them analgesics, antibiotics. If you get a lot of fluid in the pericardium, then you may have to do a pericardiocentesis. Anyone who's had pericarditis is at a risk for pericarditis again. So these patients should remember the signs and symptoms if it happens again. If somebody has constrictive chronic pericarditis, they can take the pericardium out. You can live with your pericardium taken out. That's called a pericardiectomy. So myocarditis. Myocarditis is diffuse inflammation of the myocardium, the whole muscle. It's usually viral. It also is going to cause pleuritic chest pain. Pericarditis often accompanies myocarditis. So because of the myocarditis, we're going to treat the patient with DIG because you can develop some dysrhythmias. So, for example, AFib, a flutter. The thing that happens with myocarditis is you end up having problems with this is classic, your knees, ankles, elbows, and wrists, inflammation and tenderness. So you have mono or polyarthritis in different joints. The other thing that happens with myocarditis is you have what's called erythema marginatum. So you have bright pink map-like lesions on your trunk. And those are exacerbated by heat, like a warm bath being out in the sun. Here's an example of that. So looks like MAP. So that's what that looks like with a patient with myocarditis. Rheumatic fever, heart disease. Oh, well, that's all we're doing for that one. Rheumatic fever, you realize we're going to talk about a little bit on another one. Rheumatic fever, has to do with when your valves are attacked. So patients, when they were little, years ago, this was a big thing. Rheumatic fever the valves, the attacking of the valves, so it causes valve problems. You don't hear about it that much. Okay, valve issues. The most common valve that we have problems with is the mitral valve. Where is the mitral valve located in the heart? But you can have a valve problem with any of the valves. Mitral valve is number one. That is, I'm not going to tell you where it is. You figure it out. So, echocardiogram, you can look at the valve that way. Chest X-ray, you might see something, maybe not. But if your heart's enlarged, you can see changes on an ECG. You can do a TEE, really good way to do that one, and see if there's any changes. They'd look at the valve. You could do cardiac cath and get really good pictures. Check the EF, see what's going on. Symptoms. Somebody that has mitral valve problem or any valve problem, especially mitral, is you're going to be short of breath. So again, we're causing problems, having problems with cardiac output. So fatigue on increased activity. They may have a cough because the blood is not doing what it should do with the valve problem. You've got heart palpitations, swollen feet and ankles because the blood is backing up all the way from your mitral valve, heart, through the lungs. So you've got edema. You're probably going to have a heart murmur, so an S3. You're going to have excessive urination. So that ends up being what you're probably going to have. So treatments, it basically depends on the severity and the progression. So how bad is it? Do you need to replace a valve? Can you treat it? Blood pressure, diuretics, low salt, same kind of things we do for heart failure. And antibiotics. Anybody that's got a bad mitral valve, it's imperative that they have antibiotics for medical procedures. So like taking a tooth, having a tooth extracted, things like that. So signs and symptoms, obviously, fever, malaise, anorexia, don't feel like eating, pain, arthralgias. So if you have mitral valve regurg, you basically have the problem of you need to see your dentist regularly so you don't have, it doesn't become worse. You need to have a healthy diet. You need to cut back on caffeine and alcohol because it can increase your dysrhythmias. So these patients usually have mitral valve problems. They're going to have AFib or a flutter. They should be exercising under doctor's permission. So mitral valve problems we talked about in class. Remember, you could have regurg or you could have stenosis. Mitral valve stenosis and also tricuspid valve stenosis or regurg. Stenosis is when it's basically fused so it doesn't open, so it's like a mouth, a fish mouth. Regurg is it doesn't close well enough and blood flops back into the atria. So stenosis and regurg are two different things that can happen with your valves. So surgery, you're going to basically have severe symptoms. If it's bad enough, let's do a valve repair or replacement. So what kind of valve replacements can we have? Well, autograft valve is we take a valve from another part of the heart and change it. That's not very common. Homograft valves are valves taken from a deceased human donor. Heterograft valves that come from an animal, pig or a cow, or mechanical valves. So there's pros and cons with all this. Mechanical valves last the longest. The problem with mechanical valves, you have to take anticoagulants the rest of your life. You don't have to take anticoagulants with the homograft or the heterograft, and luckily you don't have to take anti-rejection with either of those as well, because there's not a lot of blood circulation in the valves themselves, so they're not going to reject. So you may say, well, then I want a heterograft valve. Well, if you're young at age 30, those only last approximately 15 years. So they may say, no, you're going to get a mechanical valve because, you know, it's going to last longer. If you were getting a valve replaced at 65 or 70, maybe one of the other one's the best thing. So here's a picture putting a valve in. They're suturing this in. There we go, a valve. Here's an example of a stenotic valve. Notice it's very like fish mouth. This is frozen. Here's another good example. There's stenosis valve. Here is a tricuspid valve, and notice we have vegetation growing on it. That is an example of basically endocarditis. So it's growing on the valve.